being a
anemia of Bharat. Right.
All it from 6 months to 90 years,
Right.
irrespective of their status of
Right.
And whenever you find that there is iron deficiency or different types of anemia, you should treat accordingly. But you should always supplement iron for those from 6 months to 90. So that is my
Right. Absolutely true, sir. Point well taken. Yes, Dr. Manas.
I have one question. Thank you, Dr. Mukesh, for a wonderful presentation. My question is regarding the splenectomy at 1 year age for a child with pyruvate kinase deficiency. So if we look at thalassemia, we just see transfusing them, and if you have to do a splenectomy for BK deficiency, you can do it after 7 years, 8 years of age, and treat them like THALS. So why would you decide to do a partial splenectomy early and then do a full splenectomy later?
Right. So sorry, it was cut short. The child developed aluminization. We were finding it tough to transfuse, so that was the reason why we took that. Right. Exactly. I didn't include that in the slide just to cut it short. Any other question? Right. Thank you.
Thank you, Dr. Mukesh, for such a wonderful presentation. And I thank all the chairpersons for the participation. Thank you very much. Next session we have on hereditary angioedema. For that, we have the chairpersons. We welcome Dr. Dheeraj Shah. He is the Director, National Institute of Health and Family Welfare. We welcome him. We welcome Dr. Vasudevan. He is the Secretary, IP Delhi Central Branch. And we welcome Dr. Shravan Gupta. He is the Secretary, IP West Delhi Branch. We request them to please invite the speaker. Thank you.
Next topic is hereditary angioedema. The speaker is Dr. Anu. Dr. Anu is the associate professor in the Lady Argo Medical College. Her areas of interest are pediatric dermatology and oncology. Currently having more than 50 publications in national and international journals. Dr. Anu.
Do I just move the slides? Yeah. Okay, good afternoon, everyone. I thank the organizers for giving me this opportunity to present this rare entity. I promise I'll make it very, very simple. And I hope at the end of the talk, we are at least able to understand this entity, at least understand the approach to this, and finally the therapies. So first of all, I know we are all pediatricians, and the commonest problems we see are atopicity, asthma. So commonly what you might have seen is urticaria associated with wheals, pruritus. But angioedema is not like that. It is little different. There is swelling. The swelling is deeper than the dermis. And it is not mediated by mast cells, it is mediated by bradykinins. So obviously, when you give the anti-allergics and mast cells inhibitors, they do not work. So you need a therapy which is different. So I'll be mainly talking about the hereditary angioedema, and specifically the hereditary angioedema that is caused by the C1 inhibitor deficiency. So it's a very, very old disease described way back in 1800s. And by 1960, we knew that it was because of a serine protease inhibitor defect. So obviously, like any other disease, it's divided into various types over the ages. So we have the type 1 where you have the protein which is low, the function is low. And you have the second variety when the function is defective, but the level may be normal or increased. Over the years, in the year 2000, we came to know there were some entities, some patients who presented with angioedema but had normal C4 and C1 inhibitor defects. I'll be talking about those in very short way. And the commonest gene which is affected is the SERPING gene. It's a very uncommon disorder, 1 in 50,000 to 1 in 10,000. And in India, by doing the statistics, we know about 30,000 patients we are anticipating that they are living in India with this disease. And obviously, it is under-recognized because it's rare. And it is an autosomal dominant disorder. The pathogenesis is because of the C1 inhibitor defect, which leads to accumulation of bradykinin. We all know that the bradykinin is a vasodilator and it leads to edema. So that is why, because the muscles are not involved, your anti-allergics do not work. So, like I said, type 1 and type 2, the commonest one is the type 1, where you have the low C1 inhibitor and low C4 levels. While the type 2 occurs because of the defective protein. You can detect it in the plasma, but the functional assays would show that it is not working. So a novel type, like I said, is discovered in after 2000 when genetics became available, and these patients did have defects in the pathways that are that may or may not be bradykinin mediated. So we all know that the contact system, the coagulation system, the fibrinolytic pathways, and the prekallikrein pathways are all interconnected. So defects accordingly are in those pathways. So clinical features, we must remember that there is no urticaria and there are no wheals. It's just a swelling, which is usually non-pruritic, non-pitting, and asymmetric. It can involve any of the extremities. It can involve the face, lips, ear, and your legs, lower limbs. And typically the attacks are gradual, but they worsen over the first 24 hours. If you have a swelling that goes away in 24 hours, it's not hereditary angioedema. Or if it responds to your antihistaminics, even then it is not hereditary angioedema. And usually they are self-limiting, and 48 to 72 hours is the time when they go away. But sometimes it may take up to 5 days. Commonly is the abdomen and the lower limb extremities. And what is the danger? If it is all self-limiting, why are we so worried about this illness? We are worried because the upper airway and laryngeal involvement can occur anytime in any patients, and there are not really many predictors that will tell you that this patient is at a risk or he's not at a risk. So this is a very life-threatening illness, and other organs like kidney, brain, joints are rarely involved. So the commonest one, where you have the C1 inhibitor defect, where your bradykinin runs unchecked, the attacks are highly variable. And they may just complain of abdominal pain. The children may come to you with abdominal pain and might have had a history in the past. Like, okay, he might have had some angioedema, which may have subsided on its own. And now he comes to you with abdominal pain. That's the situation where you might like to think of this entity. And most of the children do begin to have symptoms before 10 years of age. And puberty, pregnancy, where you have estrogen containing drugs, there, if the patient is exposed to that, then the symptoms can worsen. It is associated with prodrome. Every patient has a prodrome, and he knows when the symptoms are going to occur. And the commonest one, we are saying that there is no pruritus, there is no wheals. Yes, I still stand by that. But some of the patients may have an erythema marginatum like rash prior to he has an angioedema. So this erythema marginatum may be mistaken for an urticarial vasculitis, and it may miss the diagnosis. So other symptoms like fever, malaise, fatigue may also be there. And the most common triggers are trauma. Trauma and emotional stress, basically stress of exams, stress of personal life may lead to attacks in the adolescents. So like I said, the system involved are cutaneous, the face and lips, gastrointestinal, laryngeal, and upper airway. So when they have, like I said, there's another entity where you may not get any defect in C4 or C1 inhibitors. This is known as C1 inhibitor normal HAE. So what does that mean? These children have later onset, more prominent involvement of the tongue, uvula, and the face, and the swelling of the tongue may be diagnostic of this subtype. There's less frequent abdominal attacks. Females are more often affected. and diffuse cutaneous findings in the form of hemorrhages and easy bruisability, but erythema marginatum is not reported here. And there's lower penetrance of these genetic disorders, so you might find asymptomatic carriers. This is a family that came to me in the OPD with both the kids having swelling which occurred just before their exam or just before some stress, some performance, or maybe after prolonged sitting in a bus. So these two siblings, when we worked them up extensively, and the mother also had symptoms. So we called the mother. I think all of you can appreciate how swollen the mother's face is, and it's a non-fitting asymmetric edema. When we worked up these children, they did not fall into type 1 or type 2. They had a type 3 defect, and genetics proved that it was a defect in the connexin gene, which is a part of the contact system. So when do we suspect? If the patient has recurrent angioedema without urticaria, unexplained episodes of self-limited colicky abdominal pain, and he or she may or may not have had a history of cutaneous edema. There might be an unexplained upper airway problem. Recurrent episodes in a patient who is less than 30 years should be hereditary angioedema, while if it occurs after 40 years of age, then it is probably an acquired variety. And of course, when this swelling, when a patient comes to you, you give antihistaminics and he doesn't respond, then you should think of hereditary angioedema. And if you find that these angioedemas have a particular trigger, then also it will be prudent to think of this entity. I'll come to the diagnosis, and a low complement level, especially if the levels are less than 10 milligram per deciliter, should alert the clinician to the possibility of this entity. So a few points that we need to remember that though family history is there, it was present in the kids that we saw, but family history may not be present in up to 1/4 of the patients. And recurrent abdominal pain may also be the only finding. Family members should be screened. C4 levels should be assessed. So we have 3 investigations that we are supposed to do. Very, very simple. Do a C4 level, do a C1 inhibitor enzyme level, and if it is normal, then go ahead with the function. And if the onset is more than 40 years of age, you would think of acquired hereditary angioedema. This is not the age group we deal with. So whenever a patient comes to us who has a typical history, a family history, and you think that this is hereditary angioedema, you first do the C4 levels and you do the C1 inhibitor levels. If the C4 is low, that is less than 10, and C1 inhibitor levels is less than 30% of what the normal should be, you should think of type 1 HAE. If the C4 levels are low and C1 inhibitor levels are normal or high, then you should think of type 2 HAE, and then these patients should be sent for a clinical exome doing SERPing gene mutation. But in these children, what had happened was their C4 was normal. So it's a good screening test, but it does not rule out that HAE is not present. So what we did in these patients were, we gave them a antihistaminic trial. And because more common is the muscle-mediated angioedema. So how do we give it? We don't give the cetirizine in the normal doses. We give it the double of the dose that needs to be given. And if the patient doesn't respond in 3 weeks' time, you quadruple it or you add a second agent. Even after adding the antihistaminics, these children did not improve, and we went ahead with the further workup. We did the INH levels, C1 inhibitor levels, they were also normal. So we went ahead with the genetics where I told you that we got the mutation. So, but this mutation is not actually reported previously, so we are just waiting on some functional assay. So management, as we all know, there is no cure. So I hope diagnosis is very, very clear, not very difficult, only 2 tests initially. Do a C4 screening and do a C1 inhibitor. Based on that, following the flow chart, you may find where your child is fitting. And if your C4 is normal and the child is having angioedema, please do try high doses of antihistaminic drugs. So management, of course, there's no cure. And there are 3 aspects. One is like what is the acute management? If the patient comes to you in the acute attack, or if the patient has to undergo some surgery. So short-term prophylaxis and long-term prophylaxis if needed. So quickly, Not many drugs are available in India. Acute attacks should be recognized as soon as possible and should be treated in a medical facility. And the commonest way we treat an acute attack is by giving them FFP, 10 to 20 ml per kg. And if in 1 or 2 hours you see a response, well and good, otherwise you may repeat it. Another drug that is available now in our country is Celestrate 1, which is a plasma-derived C1 inhibitor enzyme. So if the patient is having acute attack, yes, it is expensive, but it is quite effective. So that is one of the drugs that is available specifically for this therapy. So every patient should have a definitive plan. Like if he has a swelling, where does he have to go? The doctors have to be involved. A pre-planned management should be given to the patient because not everyone is aware of this HAE entity. And of course, if the patient has to undergo surgery, has to go undergo intubation. If the patient is going on in the intubation, it's going to irritate the larynx and the patient may have angioedema. So you need to give prophylaxis in that situation. So I've highlighted in red the drugs that are available to us in India. One is a plasma-derived C1 inhibitor, which is available to us. It's a 500 IU vial, and we give 20 IU per kg for an acute attack. At one particular, this is self-administered. So patients should always have 2 doses of this drug whenever they are at home. We don't have the second drug available. We again have FFP available with us in our country. We also have stanozol and danazol. It basically upregulates the manufacturing of the C1 inhibitor. Tranexamic acid may also be used, but there's a risk of thrombosis and gastrointestinal disturbances. So acute management, like I said, 20 units per kg, you can either use this plasma-derived enzyme or fresh frozen plasma, which is commonly used in our country. Even though the guidelines recommend that each attack of HAE should be treated because of potential side effects associated with the use of FFP, we may decide to treat only the ones that are life-threatening. FFP should be used in the dose of 10 to 20 ml per kg, and the patients usually respond quite fast. Then short-term prophylaxis, that is, like I told, if there's a surgery or a dental procedure that the child has to undergo. And the commonest one that we use are tranexamic acid or attenuated corticosteroids. And of course, in the West, they don't usually give short-term prophylaxis because they have access to medical care. But in India, where we don't really know this entity that well, and most of the doctors are not aware of this entity, might be prudent to put them on short-term prophylaxis. In general, there's a risk of angioedema during the procedure and 48 to 72 hours after it. Patients who are already using attenuated androgens should double the dose during the procedures 2 days prior and should be continued to 5 days. If the patient is not taking attenuated androgens, and the commonest one is stanozol and danazol. So you can give it started 2 days prior and continue it for 5 days afterwards. FFP may be given a few days before if the risk is high. So long-term management, there is no definitive recommendation when to start on long-term management. You can start it in a patient who has at least 1 episode every month. In developing countries like India, it is advisable to keep a low threshold for initiating long-term prophylaxis. And the only drugs that are approved for this are tranexamic acid and attenuated corticosteroids. And in the long-term management, there's actually not much difference between danazol and stanozol, but stanozol has got a better side effect profile. The way forward, yes, we are starting to recognize, like we have 3-4 patients in our OPD. We had this family, the others did not have a family history. There is a physician society that is being formed. There's also a patient society, and the society was established very, very recently, last year only. And the prognosis is very, very variable. The acute attacks, they generally continue throughout life, unpredictable manner. And you basically need to educate the patient. Plasma-derived C1 inhibitor is currently expensive, but it's very, very effective. Or FFP is a reasonable alternative. Despite effective therapies, death secondary to laryngeal attacks still occur. We don't have any data from our country, but mortality in the West is around 13%. So to conclude, it's a rare, potentially life-threatening disorder. Every patient should have an acute plan. Options for short-term prophylaxis should always be given to the patient. Long-term prophylaxis by attenuated steroids and tranexamic acid may be used. And every patient has an individualized management, and patient education is very, very important. Thank you very much.
Thank you, Prabhu. It was a wonderful presentation. Actually, hereditary angioedema is something which is not a very common entity that most of us have experienced during our time during our practice. Very well summarized. Well, one particular question, basically what doubles or maybe what is disturbing in hereditary angioedema is the acute attack.
Yes.
Otherwise, it can be managed the way we had. That is when we come to the management.
Yeah.
So, you told me that, told us that there is nothing, no medication at that point of time will actually help, and if the patient needs to go into an incubation kind of a system. So, we can, what are the precautions that needs to be taken? You know, you told me about the FFP, we had acute management that can be able to most of the time we do not have that easily
Yes.
in a short time.
Yes.
So, what we normally as intensivist, we normally end up practicing any child who comes in with an acute attack with a very difficulty. The incubation along with EAT specialist who can manage the
Tracheostomy,
and emergency something which we consider. And steroid is something which can be given at that point of time, but we have told us alarmingly that steroid is not going to be.
It's not going to be very effective.
Yeah.
Sir, actually, the acute attack may not only be involving the upper airway. It is one of the places where you can have an acute attack. Other common places where you can have an acute attack is the GI tract. You can have obstruction. You can get the child can be extremely colicky, can present with obstruction, can have urinary retention because of angioedema. So every patient's attacks are different, and the laryngeal attacks are an emergency, and that is why every patient. There are no guidelines as of now, but I do feel that the C1 inhibitor enzyme, when you can talk to the patient if they can afford, they know that the attack is coming on, and they should be told that this drug, how to give this drug, it can be self-administered. They should start it at home, and they should have enough for 2 attacks. That is what the Western guidelines tell us. And of course, when they are rushed to the emergency, they should be rushed before the laryngeal edema, and that is the cause of death even in the West. It is tricky. The intubation is tricky, and sometimes you end up cracking them or even putting a tracheostomy. But that is just securing the airway. But angioedema as such is a self-limiting illness. So for acute attack, if you can use FFP, FFP is quite effective. But if FFP is, if the parent is affording, then you can try the Celestrase one. It's available, sir. It's available in India, but the cost is a lot. Like a 500 IU vial cost around 27,000. So if for a 20 kg child, you would need 2 vials at home. That would mean 50,000 worth of medicine kept at home. Because there's no point in going to the hospital and getting it done. It has to be self-administered at home.
I just we have one family who's got this disease.
Jesus.
Actually, I got aware because this is now considered one of the primary immunodeficiencies.
Yes, sir.
So
Absolutely.
in our immunodeficiency education lectures, we got aware about this entity that this kind of an immunodeficiency. We never knew that. And this boy had recurrent, non-itchy, unilateral swelling of the face.
Yes.
So that is what triggered us to make a diagnosis. We have put this child on a long-term tranexamic acid because it was very symptomatic and children were making fun of him in the class.
True.
His face would get disfigured, and he's doing very well. He's had no more attacks after starting tranexamic acid.
So even in this family, we started them on the mother. We started on danazol because she was not planning a pregnancy, and kids we started on tranexamic acid, and they're doing quite well. Thank you so much. And sir, another thing, like even HLH and is also, Fanconi is also a part of our PID only. Thank you so much. Thank you for the opportunity.
What is the difference between this urticaria and this headache edema in clinical basis?
Yes, sir. So, the allergic angioedema. See, angioedema may not be hereditary. You can have muscle mediated, you can have bradykinin mediated. And the allergic atopic one is usually mediated by mast cells. So they usually have itching, they are pruritic, they may be symmetrical, and they respond very, very well to antihistaminics. Like I said, these children, when they came to us, you give a good trial of antihistaminics and 2 times or 4 times the dose that is usually given. And if it subsides, then it is probably allergic muscle mediated. And if it is not subsiding, then it is probably hereditary angioedema. When you're not really sure and there are overlapping features, then it's prudent to do a C4 level than to screen them. If the C4 is low, it's a very good screening test for hereditary angioedema.
Thank you, Dr. Anu. Actually, I would just first question and then I conclude.
Yes.
As Madam has said that it is a very rare disorder, but this presentation is recurrent facial edema is not very.
Yes.
So what we really need to understand is that whether hereditary angioedema could be one of the differential diagnoses for our patient who give the history of recurrent facial edema, which is very common. As in our practice, we have found that we all know that necrosis, CKD, hypothyroidism, even some of the hematological disorders, they come with this history. So when to suspect becomes important. But now sometimes I say that hematological disorders could be having like acidity present.
Yes.
So what it is worthwhile to do a C3 along with C4, and if C4 is low but C3 is normal, then probably suspect hereditary angioedema. Whereas if both are low, maybe
Dealing with lupus.
one of the key. So but
Sir, actually, lupus presenting as angioedema, it does respond to steroids. But hereditary angioedema would not respond to steroids and
that's true, the cause is true, but when we are clinically suspecting, sometimes I feel maybe worthwhile to do that is again because.
Sure, sir.
Hereditary angioedema also you said can present with the joint sometimes.
Absolutely.
Sometimes, because these disorders are lot more common than hereditary angioedema, so it may be worthwhile to do a C3, but you are the best to decide. And I can just conclude that, as I said, that the presentation is very common, so you need to know when to suspect. So from her talk, I can summarize that whenever the recurrent patients when without urticaria, very important, because urticaria angioedema is the number one diagnosis, much more common, but where it is without urticaria, and especially when there is a family history. And there is no response to antihistaminic antihistaminics. This is the patient where you must suspect hereditary angioedema. Do a C4 with or without C3, and if C4 is low, refer to her. My best will go to C1 and because but my encounter with hereditary angioedema first was the daily entrance exam, got a question on hereditary angioedema called by my answer was right because even because I looked it up. Thereafter, suspected it in one of the where they related to the recurrent environment pain and intermittent facial edema. For reach stage before it was low, we could not manage even INH at that point. And thereafter, we have suspected a few patients, but ultimately they turned out to be something else. So definitely it's a disorder
absolutely.
which is rare, but you must know when to suspect and when to refer that. Thank you.
Thank you, sir. Thank you, sir.
Thank you, Dr. Anu, for enlightening us on these rare disorders. I thank all the chairpersons for their discussion and the participation. Thank you, Dr. Dheeraj Shah. Please be careful. Thank you, Dr. Shawn. Thank you, Dr. Vasudevan. And now I invite Dr. Mukesh Dhankar for the next session.
So basically, thalassemia is an autosomal recessive and also the most common inheritable blood disorder, genetic disorder. So if we look at the Indian circumstances, the average prevalence is about 3 to 5% carrier rate in our Indian population. So which translates to about 35 to 45 millions in our community. In our community out of 1.5 billion population. So this translates to about 1,000 to 10,000 to 12,000 deliveries per year. So this is a lot number of thalassemia which are born. So each year, 8th of May is celebrated as the Thalassemia Day. But we thought we'll take this opportunity to invite, as we have all the dignitaries and all the senior colleagues, hematology colleagues and senior pediatricians. So are here, we would like to celebrate the Thalassemia Day. For that, I would like to invite Chandra sir on the stage. I would like to call Dr. Manas, Dr. Kiran ma'am, Dr. Arun, who is managing the Thalassemia and DDU. Arun sir, please. I'd also like to call upon the office bearers of Delhi IIP, Dr. Mukesh Sharma, Dr. Bhandari, Dr. Ajay, Dr. Puneet, who is managing at MEMC, please, Dr. Anu, who is our colleague at Kalavati,
Yogesh Parekh,
Dr. Yogesh Parekh, sir,
Vice President.
Vice President,
President.
Dr. Lalit, sir. Sir.
Dr. Bani. Dr. Bani.
Dr. Vani, sir, please. Dr. Ashraf.
Dr. Ashraf, sir.
Dr. Renu, Dr. Nehal, please join us. Dr. Ashwini Syal, sir. Dr. Chandramohan, Dr. Ajay Srivastava, sir. And Dr. Anil Tiwari, sir. Please join us. Dr. Lalan, please bring everyone along. Dr. Piyush. Dr. Piyush Khanna.
आप इधर आ जाए सर, थोड़ा आगे पीछे हो जाए। Yes, look here, please, sir. Sir, look here, please. Sir, look here, please.
For the next session, I would like to invite the chairpersons, Dr. Shalini Pandey and Dr. P.S. Naran, sir. I would also like to invite Dr. Mohini ma'am to be a chairperson for this session. And over to the chairpersons to invite the speaker for this session, please. Thank you.
Guidelines for the management of thalassemia. Very warm welcome and good afternoon to all the delegates. And it's very important that the three main motives of a pledge to be taken on World Thalassemia Day is number one, the prevention and the prenatal counseling of all parents would be, and how we can prevent by doing the thalassemia screening. The second is the best possible management for all the patients we have, so they don't end up with problems which subsequently can happen to thalassemia. And the third and another important part which we are succeeding now is the bone marrow transplant for these patients. So to address all these issues, we have Dr. Rajdeep Chandra. I welcome Dr. Rajdeep Chandra, and to highlight to all of us for the management of thalassemia. Thank you.
Thank you, Mr. Chairperson, and thank you, the organizing team, for inviting me for this talk on thalassemia guidelines and making it a kind of mini celebration for International Thalassemia Day, which was on 8th May, the last Monday of this week itself. So, for those of you who are looking forward to the guidelines on management of thalassemia, I think I would disappoint you, because I am not going to discuss the management of thalassemia here. It's just that why these guidelines were made and what these guidelines contain. That is what is the discussion point here in next 15-17 minutes that I will be doing. So Dr. Mukesh highlighted the prevalence, which is very common, and there are over 1 lakh of thalassemia, transfusion-dependent thalassemics who are currently living in our country in different shapes, different shades of management, and there is a lot of diversity. If you move out of Delhi, in fact, in Delhi also, if you move out of the larger hospital to the smaller hospitals, the management changes. And in the forward, or rather not forward, the initial chapter of these guidelines, Dr. Mamta Manglani has very rightly pointed out, though we are proud in our country of diversity of our cultures and everything, but this diversity is really unwelcome. So the major thrust was that the treatment of thalassemia should be uniform and there should be country guidelines. Again, I will further highlight what were the reasons why we thought of making these guidelines. So we know that the treatment includes the curative treatment, which is stem cell transplant, which is there in our country for almost 3 decades now. And the gene therapy is on the horizons. Maybe in a couple of years, we would start trials in our country on gene therapy. And incidentally, you would be happy to note that one of our PGs from Kalawati Children's Hospital and alumnus of Maulana Azad, MBBS from Maulana Azad, PG from Lady Harding, Dr. Sandeep Soni is the person who is the mastermind at present on this gene therapy, and we will soon have the trials happening in our country. And the conventional treatment we know include the transfusion, iron chelation, the two arms which were there, and to which repeated conferences we have highlighted that monitoring is something which is very important, and of course the treatment of complication, and as highlighted by the chairperson, the preventive aspects. This is the total management. There are guidelines available. IAP made the guidelines way back in 2006. Certainly they needed to be updated. Then the National Health Mission guidelines, which were there in 2016, which are available in the book form, but not very widely circulated and not a detailed one, because you can see that these are the guidelines on prevention and control of hemoglobinopathies, which includes the management as well, but not all those details are available in these. Then mostly we keep following these Thalassemia International Federation guidelines, which you can see the extreme left is the guideline which is available mostly. The middle one is 2021 guidelines, recent ones on the transfusion dependent thalassemia, and on the right side you see the specific guidelines for the management of non-transfusion dependent thalassemia. These are the terminologies which are used for major and intermediate, the transfusion dependent as well as non-transfusion dependent thalassemia. So, and International Thalassemia Day, the logo for 2022 of TIFF logo was Be Aware, Share and Care. That is working with the global community as one to improve thalassemia knowledge. So you can say that it was probably a chance that our thinking also went ahead in this direction on making the guidelines for our country, because we have our own specific issues. We needed to update doctors on newer developments regarding the gene therapy, availability of stem cell transplant, even financial help available to the poor patients. There is a lot of talk on HbF inducer drugs, particularly two, the luspatercept and thalidomide, and the disability certification, etc. These are certain new things in the field of thalassemia management. So we needed to highlight that there is country to country variation in the management guidelines, and we needed our role. Like, for example, in chelation and its monitoring, what is the first chelator to be used? We will see in some next 5 to 6 slides. This is a area of debate in different countries. When to begin the combination of chelators, and which combination to be used, and when to begin MRI-based monitoring for iron overload. So there is a lot of variation here. Now look at this starting iron chelation. The TIFF guideline says you should start with desferrioxamine in the dose of 20 to 40 milligram per kg. But look at USA says deferrasirox, UK, Europe and Canada, they talk of desferrioxamine. Australia talks of deferrasirox. So where we are, though we use deferrasirox, but it has not been said firmly that this is the first drug to be used for iron chelation whenever we need. Now, combination therapy, this 2021 TIFF guidelines also said that true combination therapy is widely practiced, although not specifically licensed. This can be useful when monotherapy is inadequate, either to control iron balance or to control iron distribution, particularly in the heart. So the guidelines are required for actually, point out that at what point in management of thalassemia, you need to start combination of iron chelation. So just look at this. Is this not working? Yeah. So you can. So you can look this box here, the frequency of monitoring based on cardiac MRI. I think we all know that when iron overload occurs, the best way to monitor is by doing the MRI of the heart and MRI of the and based on the MRI, we decide what frequency we need to do repeat MRIs, and there is a lot of variation. You can see the Australia, Canada, UK, US, and Italy guidelines, and the frequency is maybe at 6 months or maybe at 2 years, depending upon what are the cutoffs, and there is variation in that. So Italian guidelines would say that intensive chelation with DFO or combination with DFP or DFO is recommended for serum ferritin or of more than 3000 for which persists for about 3 months. Liver iron concentration of 15 milligram. These are on guidelines on the combination of the iron chelators. And cardiac MRI shows when the T2 star is less than 12 milliseconds and cardiac dysfunction is there. So these are the Australian guidelines. We take into account the age and like 2 years and 4 years, and then this is the starting of the ferrosirox, and then looking at the cardiac status and the serum ferritin as well, and the T2 star values to monitor the decisions is that way is based on the age and cardiac dysfunction. So Canadian guidelines, they at 1000 we start chelation, and at 2500 they decide to add the combination or intensive chelation, and in terms of LIC it's the 15 milligram per gram of dry weight of liver. So again, what combination to be started, that is also variable. Like here the deferasirox as well as desferox, deferiprone and desferoxamine combination is decided. So I didn't want to overwhelm showing these the guidelines of different countries, but just to highlight that the guidelines are varied according to different countries, their preferences and their concerns about the safety of the drug. So these guidelines which we have come out in national evidence-based guidelines of PHO IAP, it would tell you that when to start iron chelation, what chelator to start with, mostly monitor with serum ferritin, MRI to be done at 10 years of age, and later on based on what are the MRI values. So guidelines provide clear indication for combination of deferiprone and deferasirox, 2 oral iron chelators rather than adding desferoxamine based on serum ferritin. That is, we have come out with a cutoff of 2000 rather than 2500. And when MRI shows the LIC values and T2 star values, that is when to switch on to the combination. Now, next issue was that there's a lot of talk about drugs that bring down transfusion requirement and what is the current status of that. So this is a new drug which has come up in the market just last month. It was made available, luspatercept. This is a drug which promotes terminal maturation in immature erythroblasts, and that is how it increases the reticulocyte count, and it increases it decreases the ineffective erythropoiesis, which contributes to development of anemia in patients with thalassemia. Now, this is available in the vials of 25 milligram and 75 milligram. It would be interesting to note that this drug is to be given subcutaneous every 3 weeks, and in almost 1/3 of the patient, it brings down the transfusion needs by nearly 1/3. But the cost is prohibitive. For a 30 kg patient, it would cost something like 70 to 75,000 rupees a month. Not really within reach of many of our patients. And we really don't know which of these patients who are started on this drug would be in whom this would be effective. So this drug has been approved by our DCGI for a phase 4 study in patients with iron overload, including transfusion-dependent thalassemia, adults, not the children. Still, it's not approved by the DCGI for the use in children. In fact, FDA also has not approved. The other drug that we are hearing over the last 2 years is thalidomide. There are several studies now from India on use of thalidomide for decreasing transfusion requirements in both anti-DT and TDT. There are combinations, the thalidomide as well as hydroxyurea and thalidomide alone, but still the long-term safety is not known. So the guidelines will tell you what to do about the use of thalidomide as well as luspatercept in our patients. We are all aware that bone marrow transplant is available in our country, but the cost is still prohibitive. No know-how for doing transplant is now very easily available. I think there are some maybe 15 odd centers in Delhi NCR where bone marrow transplant is being done, but it would cost around 15 to 20 lakhs for a allogenic transplant. But it's important to know that for poor patients where a sibling donor is available, mass sibling donor is available, at least finances are available. Whole India project through which almost 200 transplantation have already been done. And this is being extended to not only thalassemia, they are extending it to aplastic anemia as well. It may be a very small thing like folic acid supplementation, but there is something new in this. We all co-prescribe folic acid, 1 tablet daily to thalassemics. It's not all that harmless as we now understand. The high levels of folic acid may be little problematic as well. So this study which was done at UCMS, they compared 3 doses, 5 milligram per day, 2.5 milligram per day, and 5 milligram per week. And they found that the levels in the patients with thalassemia are same, whether you use once a week therapy or daily therapy. So our recommendations are again taking into account these publications as well. The next thing, the guidelines also contain about availability of disability certificates. They are now in the ambit of the disability certification, the thalassemia patients, and the benefits should be made available to them. All large hospitals have certification boards made of physicians and pediatricians. Wherever pediatrician is not available, physicians and medical superintendents, and this thing is available for getting admissions into higher studies as well as in the jobs. So the guidelines include details of diagnosis, details of transfusion chelation monitoring. It also talks of monitoring and managing all systemic complications, including endocrine, cardiac, growth-related, and transfusion-transmitted infections, management of anti-DT, and management of fertility in patients with transfusion-dependent thalassemia. It would also tell you there are chapters on how to start thalassemia daycare center and transition of care of adolescent to adult side. This is something regarding thalassemics. This topic is very close to my heart. When the patients are older than 18 years, should only pediatrician continue to manage these patients. And I'm proud to say that in Lady Hardinge Medical College, in fact, this is the only medical college in the country where 2 separate departments are in thalassemia daycare center, and we have transferred almost 140 patients to our physician colleagues for management. And oldest of the thalassemic patient from Kalavati Saran Hospital is almost 41, 42 years old. And what is the support available to these patients in the form of NGOs working for thalassemia patients? So these are all important when you are managing such a chronic condition. The patient requires various types of support, which the doctor alone may not be able to provide. You need counselors, you need counseling teams, and that is where the NGOs like NTWS and Thalassemics India, they chip in with their support. When the need was felt, the INFOC subcommittee on hemoglobinopathy and other red cell disorders, actually, the PHO chapter started with something called INPOG, INPOG, that was India Pediatric Oncology Group, on the lines of Pediatric Oncology Group of USA. And then when the pediatricians like me cried harsh that include benign hematology also, Manas is smiling. So on our repeated request, the H was included here, and this became from INPOG, it became INFOG. And there are benign disorders subcommittees, where one is on subcommittee on hemoglobinopathy and other red cell disorders. And I am the first chairperson of this subcommittee. And PHO of IAP, we took the initiative. In fact, I requested Dr. Mamta Manglani, who is a senior pediatrician, pediatric hemato-oncologist in our country, to lead the group, and Neeta Radhakrishnan, who is the head of the Department of Pediatric Hemonc at Pediatric PGI at Noida. She was the secretary of this group, and she wrote in 60 experts and writers, including some super specialties, for making these guidelines. There were several online meetings, and then when the topics were written, they were available. The team of 8 reviewers and editors. They were repeated checks and revisions, and finally it took the shape of a book, which was this is the face of the book, and this was released on 8th May by DG ICMR, who is in the center, Dr. Rajiv Behel. And the president, IAB, Dr. Upendra, was there in this meeting. This was released in Constitution Club of India on 8th May. And fittingly, the International Thalassemia Day 2023, the TIFF, the logo was strengthening education to bridge the thalassemia care gap. And I hope that these guidelines will really bridge the gap in the knowledge of thalassemia care in India. So I think that's the last slide. Thank you very much.
Excellent presentation. With so much experience you have. Tell me the ideal age when one should think about doing the transplant in this patient. I mean, waiting for multiple transfusions is a complication. The results become less. So, what is the ideal age one should look at these transplants?
Yeah, actually, transplant should be done when the patient has received minimum of transfusions, because as the number of transfusions received increases, the chances of rejection increase. So that is one. The second is that the center where the transplant has to be done, one has to see that centers under own understanding at what age. By and large, most of us recommend that by 2 years of age, one should decide that a transplant should be in place. So once the diagnosis is made, say about 9 months, 1 year of age, and you spend time telling the family, arranging the funds if they are required, arranging a donor if it is required. If the elder sibling is there, the best is that if the sibling is matched, fully matched, or the comfort level of the transplanting team, because now I'm not actually a transplanter, so I don't know much detail. Maybe Manas can add if something he wants to add on that. But by and large, it's almost 2 years age when a transplant can be done very easily.
Yeah. Transplant can be done even with 1 year. I mean, 2 years is the ideal, and of course, many centers in the country are coming up with the help of the Ayushman Bharat. I mean, transplant costing around 20 lakhs, 50 lakhs. So that much charity is coming from Ayushman Bharat for people.
Yeah, that's right. So there is availability of funds from various sources. The earlier also there used to be like Pradhan Mantri Sahayata and Mukhyamantri Sahayata and Vidhayak and MPs and all those funds were available, but it was maybe it was not very easy to tap them actually. So now through Ayushman Bharat, it's not all that difficult, and Coal India, and that's what I said, that the support which is available, one has to know that you rather than you yourself spending time. I mean, Manas is a busy hematologist in the city, and he is a transplanter as well. I'm sure he doesn't have time to look into this ke kahan ja karke kaise aapko funds arrange karne hain. So he'll send to some counselors team, and they will manage these things. So that support is now available, and things are not all that difficult that used to be earlier.
Thank you, Dr. Sundar, for very excellent talk.
Thank you. Thank you. My pleasure. Thank you. Oh. Yeah, I think. Yes. Yes. Actually, you are very right that the prevention is something which is most important, and you would be surprised that we submitted the prevention program draft to the DGHS some 20 years back, but nothing happened on that. Now this DG is wanting that prevention should be in place, and we have put our request. I think this prevention program will roll out soon. Thank you.
Please, okay, I want to give a comment. Sir, it witness to the fact that there was a little mini WhatsApp ad which is being circulated in India, and all the groups have circulated that, and it requests all pediatricians to include HbA2 level in the vaccination card. I think that can be a wonderful thing if we know what is the HbA2 level of your patient. You know whether that patient is a thalassemia minor or not. And right from the beginning, we are able to tell, okay, this child has thalassemia minor. Whenever the marriage is happening, see the partner, and that it can be a start to, eliminating thalassemia from our country.
You're very right, sir. I mean, prenatal counseling and including all these things to know more about the carriers in our country. We should be strengthening. Perhaps, I mean, a lot more cooperation needed from the obstetricians, that this should be part of their screening. And when you have a good prenatal care, no more children with thalassemia should be born. Thank you.
We thank Dr. Jagdish sir for such a wonderful presentation, and I thank all the chairpersons also. Dr. Naran sir, Dr. Moini ma'am, Dr.
Thank
Shalini
you
Pan.
all organizers for inviting us for this. Thank you for the good participation from everybody. Thank you.
And now I invite the chairpersons for the next session. I request Dr. Ellen Taneja sir, he is the chairperson of the ALS BLS group of IAP. Dr. Manas Kalra is senior pediatrician and hematologist at Sir Gangaram Hospital. Dr. Dhiren Gupta, senior pediatrician intensivist at Sir Gangaram Hospital. I request Dr. Manas to please invite the next speaker.
Thank you. Also a big online seminar registration within for education program for the advertising, and the response has been just amazing. So it has been hard of all the pediatricians. So thank you. I would now like to request Dr. Puneet to please come on the stage. Dr. Puneet is a dear friend, and she will be talking on aplastic anemia. I know you will think that aplastic anemia, हम pediatrician हैं, हमें क्या करना है, हम तो सीधा refer कर देंगे. But I'm sure Dr. Puneet will tell all of you that without you, no hematologist can manage a difficult hematology case. You need your support, we need your guidance, we need your help at every stage when a challenging case like aplastic anemia comes. And with newer therapies, there are many other forms of treatment which are coming up, where again partnership with a pediatrician is going to become important. So over to you, Dr. Puneet, who will talk about aplastic anemia.
Thank you, sir.
So you
Yes.
start with like one point I want to clarify. This HbA2 which you talk is after the misleading values before that. Before 100 institutions. Maybe start
गाइडेंस चाहिए और प्लानिंग चाहिए, नहीं तो इस पे काम नहीं होगा.
Thank you so much, Dr. Manas and the chairpersons for starting the session on such a funny anecdote. And so also thank you to the organizers for inviting me for this session today.
It humbles me to be presenting this in the presence of such celebrated pediatricians from all over the country. My topic for today is aplastic anemia. I will not be going into the details of it, but rather I would touch and have a brief overview of the topic for the general pediatrician. So what exactly is aplastic anemia? Aplastic anemia is characterized by variable degree of peripheral blood pancytopenias, which means there is a paucity in at least 2 of the 3 blood cell lines, that is red cells, white cells, and platelets, and it is due to decreased production in the marrow. So that is important because as pediatricians, you will come across several causes of pancytopenia. There are 2 important mechanisms that are to there. One is the decreased production in the marrow itself, which is aplastic anemia, and the other is due to increased peripheral destruction of the cell lines. So here today we will focus on the decreased production, that is aplastic anemia. So the severity of aplastic anemia was based on Camitter's criteria. This was actually identified almost 40 years ago. What you need to know here is that there are 4 parameters based on which we define the severity: the bone marrow cellularity, reticulocyte count, ANC, and platelet count. In severe and very severe anemias, aplastic anemia, the bone marrow cellularity is reduced to less than 25%, and this is in combination with any 2 of the following factors, that is retic count less than 20,000 per cubic millimeter, ANC less than 500 per cubic millimeter, and platelet less than 20,000 per cubic millimeter. When this ANC is less than 200, we classify it as very severe anemia. When there is some degree of bone marrow hypocellularity with some variable degree of pancytopenias, but it is not meeting the criteria for severe or very severe aplastic anemia, then we call it mild to moderate or hypoplastic anemias. And why is this distinction important? It is because it will actually modify what sort of treatment you're going to choose for the patient. What is the epidemiology? Definitely it's a rare disorder, but you need to have an insight and need to suspect when it is present because the therapies are going to be specific. So the incidence is 2 to 2.3 cases per million per year worldwide, but within Asia, it is almost 2 to 3 folds of this. There's no gender predilection. And normally we say that there are 2 bimodal peak of distribution. One is in young adults, around 20 to 25 years. Another is beyond 60 years of age when people develop aplastic anemia. But within children and adolescents, the median age of presentation is around 8 to 9 years. Now, as far as etiology is concerned, we would divide aplastic anemia into 2 broad varieties. The acquired form, which comprises almost 70% cases of the aplastic anemia. This could be secondary to certain drugs or certain infections, certain immunodeficiencies, or autoimmune disorders. But even within this category of acquired aplastic anemia, almost 70% cases are idiopathic, where no known reason is identified. The second group is inherited or congenital aplastic anemias. This is the same as the inherited bone marrow failure syndromes, the most common of which many of you would be knowing, Fanconi's anemia. Others are dyskeratosis congenita. So this comprises almost 30% cases of aplastic anemia. Why is this distinction crucial? Because it is again going to differ your management. Now, what are the specific underlying etiologies of acquired aplastic anemia? 70% cases are idiopathic, we've already discussed. Now, the other reasons could be, some of these you already know. For example, radiotherapy or chemotherapy. Any child who's receiving chemotherapy, around 2 to 4 weeks post receiving that chemotherapy, they will have bone marrow suppression and pancytopenia. This is due to direct injury of the hematopoietic stem cells due to the chemotherapeutic agent. Again, radiotherapy beyond 5 grays to the bone marrow is going to lead to bone marrow suppression due to damage to the hematopoietic stem cells. But this form of injury is most of the times reversible. So it is sort of a reversible cause of aplastic anemia. There are certain other drugs which we use commonly in practice, for example, anti-epileptic drugs in children like carbamazepine and phenytoin, or there are other drugs like carbonic anhydrase inhibitors, acetazolamide. which can cause pancytopenia due to aplastic anemia in an idiosyncratic manner. That means that it is not dose dependent and most of the times it is irreversible. Then you have other causes like infections, which I will discuss in the subsequent slide, malnutrition, kwashiorkor, marasmus, and anorexia nervosa. Again, in these situations, the aplastic anemia is usually reversible. That is why we need to know what has actually caused the aplastic anemia. Then there is this category of autoimmune diseases like SLE, rheumatoid arthritis, and celiac disease, where apart from the autoimmunity to the specific systems, there are cells which become autoimmune to the bone marrow hematopoietic stem cells. They kill the bone marrow hematopoietic stem cells, and therefore aplastic anemia ensues. The same is the case with certain immunodeficiency disorders like CVID and ALS. There are three other categories: hypoplastic pre-leukemia, hypoplastic myelodysplastic syndrome, which is kind of rare in children, and PNH, which is again rare in children. So what are the viral infections that we think of which can cause aplastic anemia? There are several, but you should know even the common viral infections like measles, mumps, rubella, influenza, parainfluenza, they are also capable of causing pancytopenia. Why you should have this knowledge is because almost 80% of these cases have transient pancytopenia and they would resolve by their own. However, there's another subset, the hepatitis viruses, and these are more sinister. So it is said that aplastic anemia due to hepatitis virus usually occurs around 2 to 3 months after the acute episode of the hepatitis, and it is usually difficult it doesn't normally resolve spontaneously and is kind of difficult to treat. So these are the ones where you'll have to be more careful in following up. Then there is inherited aplastic anemia. What are the inherited bone marrow failure syndromes? They are characterized by increased risk of developing aplastic anemia, a specific predisposition to cancer, and characteristic physical anomalies. A characteristic example is Fanconi's anemia. I'll tell you about the phenotypes of the Fanconi's that is there. Then there could be dyskeratosis congenita, Schwarzman diamond, which is characterized by exocrine pancreatic failure and aplastic anemia. You have CAMT and Diamond-Blackfan anemia. What is important to note is that absence of physical anomalies does not rule out inherited bone marrow failure syndrome. There could be kids of Fanconi's anemia. Almost 33% kids of Fanconi's anemia do not have any phenotype of inherited bone marrow failure syndrome. So you do not rule it out just on the basis of absence of the typical phenotype. Secondly, the first presentation, almost 25% of the cases of inherited bone marrow failure syndrome actually may have their first presentation in adulthood. So again, absence of manifestation in childhood does not rule out IBMFS. So what are the clinical features? The first set of clinical features are because of the pancytopenia itself. It's easy to understand. Decreased leukocytes leads to fever and recurrent infections. Low hemoglobin is going to lead to pallor, fatigue, loss of appetite. Low platelets is going to lead to skin and mucosal bleeding, menorrhagia, or GI manifestations. And ultimately, the child may end up receiving multiple recurrent blood transfusions. Then the next set of clinical features are clues either to the underlying etiology of aplastic anemia or to alternate cases or causes of pancytopenia in your child. So these could be history of radiation, radiotherapy, chemotherapy, drugs, and chemical exposure. Important over here is to also ask for herbal drug intake. Sometimes kids come up and tell that paas ke dukaan se humne dawai le li thi. Now certain herbal medications may contain mushrooms and they may be causes of pancytopenia. The second group of etiological history is related to the infections. So history of jaundice, history of recurrent infections in the past blood transfusions, needle stick injury, or recurrent infections in the parents may suggest of infections as the underlying cause of aplastic anemia. Then there could be clues to an alternate diagnosis like the presence of lymphadenopathy and hepatosplenomegaly, which may suggest malignancy. Then there are certain clues to an underlying immunodeficiency. For example, history of recurrent sinopulmonary infections in a child with CVID, or there could be history of multi-system autoimmune involvement, neck swellings and abdominal distension like in a child of abs. Also, autoimmune conditions like SLE and even celiac disease today are known to have concomitant manifestations and aplastics. So history of diarrhea, failure to thrive, photosensitivity, rashes, polycirrhosis, they may give you additional clues. Then there's something called paroxysmal nocturnal hemoglobinuria, not very common in children, but in the case of aplastic anemia, it is important to take the history and rule it out subsequently. So it is usually manifest as episodes of recurrent intravascular hemolysis. So intravascular hemolysis would present as polar colored urine, mild jaundice, or anemia. And these people who are afflicted by PNH also have associated history of large venous thrombosis. Now, this is an alternate cause which is pretty common as a cause of pancytopenia, at least in the kind of population that we see in our wards in the government setup. So, history of vegetarian diet, inadequate complementary feeding, a child 9 to 10 months of age, also born to a mother who was deprived and not nutritionally fulfilled, history of goat milk intake, which is specifically low in folate, and history of skin darkening and tremors, and history of developmental regression. All these are pointers towards vitamin B12 or folate deficiency, which again may present with pancytopenia. So over here in this picture, you can see the typical knuckle hyperpigmentation in this child. Now, what is the history that you're going to get in inherited bone marrow failure syndromes? So there could be family history of similar syndromes. There could be family history of consanguinity. A lot of them are autosomal recessively transmitted. There is early age of onset of the syndrome, although 25% may be cryptic adulthood. There could be specific phenotypes and dysmorphic features. Some of them may have delayed development, like almost 10% of Fanconi's will have developmental delay. They may have poor growth. There could be history of unexplained fetal deaths and family history of cancers, because all these inherited bone marrow failure syndromes also have an increased propensity to develop cancer. But this cancer usually develops in the second or third decade of life. So you wouldn't get history of cancer necessarily in the child himself, but in the older family members. So these are the clues in history which you would get in an inherited bone marrow failure syndrome. Now, what are the examination clues? So here you have a child who is significantly short stature. There could be history of failure to thrive, microcephaly, and developmental delay. There could be these cafe au lait spots, so coffee-colored spots which are present, or there could be even hypopigmentation. In this child, you can see that on the left hand, there is absence of thumb, and on the right hand, there is a hypoplastic thumb. So these are all features which suggest towards, and if such a child presents with pancytopenia, this is a pointer towards underlying Fanconi's anemia. This is the typical phenotype. When you look at the face of children with Fanconi's anemia, look at their typical bird-like faces. A very sharp nose, pointy nose. They often have ptosis. They have strabismus and large ears. Some experienced people say that they look more like each other than like their family members. If you put a couple of Fanconi's anemia kids together, their phenotype is so similar that they look more like each other. So these are examination clues you could get to the Fanconi's anemia child. In association, in addition, there could be cardiovascular and renal malformations present in these children. So you have to actively look for, suspect, and look for these markers on the examination. Now here is another case where there are clues. So this particular kid, he developed pancytopenia in the second decade of life at around 13 years of age. Then this child had nail dystrophy. There is reticulate, lacy reticulate pigmentation over the lower limbs as well as on the neck, and there is oral leukoplakia. So this is suggestive of dyskeratosis congenita, which is typically characterized by this triad. Also, these kids can ultimately develop pulmonary fibrosis and hepatic fibrosis apart from the bone marrow failure. Then another one of the inherited bone marrow failure syndromes where you have exocrine pancreatic insufficiency. So whenever there is exocrine pancreatic insufficiency, there will be lack of enzymes which have been fat absorption. So ultimately, the child will present with fat malabsorption. So there will be history of steatorrhea. Then they also have metaphyseal abnormalities in the bones, which presents as metaphyseal dysostosis, and these children may have short stature. So when such a child presents, so a case of pancytopenia with exocrine pancreatic insufficiency, you should think of Schwartzman-Diamond syndrome. So now how do you evaluate a child with aplastic anemia? The first investigation is definitely going to be CBC with reticulocyte count with peripheral smear. This will show pancytopenia as well as reticulocytopenia. So retic count is important. Now, what sort of peripheral smear picture will you get for the anemia? It will be normocytic to macrocytic anemia, while the morphology of platelets and leukocytes is going to be completely normal. The RDW will be normal. So other causes of macrocytic anemia like vitamin B12 deficiency, folate deficiency, your RDW may be increased and you will get a macrocytic anemia. Platelet volume again is normal. You may get additional clues like hypersegmented neutrophils on a peripheral smear, presence of blast, which may help in alternate diagnosis, or in case of an acute infection, you may get a malarial parasite. So peripheral smear helps not only in making these pictures, but also in ruling out other possible differentials. Kidney function and liver functions are done to rule out kidney disease and hepatitis. The most important investigation to confirm a diagnosis of aplastic anemia is a bone marrow aspirate. So on the left side is a normal bone marrow. These are the fat globules which are present over here, and this is the cellular marrow. So normal bone marrow cellularity is around 50 to 80%. Now, in this case, this is an aplastic anemia bone marrow. You can see almost the entire bone marrow is replaced by fat and very little cellular elements are there. So this gives you a diagnosis of aplastic anemia. What is important is that don't, in a case of suspect aplastic anemia, just carry out an aspirate, also do a biopsy because it's going to rule out that the decreased cellularity was not just because of a poor sampling technique. Now, at the same time, in centers which are well equipped, it is said that you should go ahead and do a karyotyping in fish for an associated MDS, and also you go ahead with molecular studies for inherited bone marrow failure syndromes at the same go. There are other investigations when you go ahead, when you want to find, when you've confirmed aplastic anemia, you should rule out other etiologies. Like serum folate and vitamin B12. But this particular investigation, I believe we should be doing even before the bone marrow aspirate and biopsy, because in our country, the most common causes of pancytopenia are found to in children have been across various series have been found to be acute leukemias and B12 folate deficiency. So before going ahead and jumping into the bone marrow, it is reasonable to do a folate and B12 level. And then, of course, you go ahead with viral serologies, flow cytometry of peripheral blood for PNH, chromosomal breakage analysis specifically for Fanconi's anemia, because 30% of them will not have the phenotype. If you have found a child of aplastic anemia, you should be ruling out Fanconi's anemia because the treatment is going to be different. Then, of course, there is autoimmune disease evaluation and immunodeficiency evaluation in the form of CDID immunoglobulin levels. So this is just the next two slides are approach to a child with pancytopenia, because you will not get a child who will have aplastic anemia. You will get a child with pancytopenia, and then you'll have to decide how do I approach it further. So if this child has hepatosplenomegaly, then actually aplastic anemia goes down, because aplastic anemias per se characteristically do not have any hepatosplenomegaly. In this situation, your differentials will be acute leukemias and infections, which are the commonest cause of pancytopenia in children in India. Then hypersplenism, HLH, hemophagocytic lymphohistiocytosis, storage diseases, autoimmune diseases, megaloblastic anemia, and myelofibrosis. In these situations, before going ahead with a bone marrow, you need to rule out these causes with other less invasive investigations. If you do not find any diagnosis despite these baseline investigations, then you go ahead with a bone marrow, and especially if you have suspicion of acute leukemia, myelofibrosis, or HLH. However, if you have a child of pancytopenia without hepatosplenomegaly, then the differentials narrow down to acquired aplastic anemia, inherited bone marrow failure syndromes, subleukemic, leukemic leukemia, MDS, certain autoimmune disorders, megaloblastic anemia, immunodeficiency. At this point, first do a B12 folate level, then go ahead with bone marrow aspirate and biopsy, which is going to differentiate between aplastic, MDS, and leukemia. And then subsequently work up for the other etiologies of aplastic anemia, which I elucidated before, like viral markers, immune markers, immunodeficiency markers. So these are the ones that I would tell you. Now, treatment, if it is mild to moderate aplastic anemia, regular and long-term follow-up is required, as almost 2/3 progress to severe aplastic anemia. Yes, this is the second, almost done, sir. And in case of severe aplastic anemia, HSCT is the preferred and curative treatment options with a matched sibling donor. Immunosuppressive therapy can also be used, and survival is also found to be equal. However, the risk of later complications like incidences of cancers, incidences of myelodysplastic syndrome is higher if a child is treated upfront with immunosuppressive therapy as compared to a bone marrow transplant. So if available, bone marrow transplant is the treatment of choice. IST consists of anti-thymocyte globulins, cyclosporine, growth factors, and methylprednisolone. Of late, thrombobantin receptor agonists have also found to be helpful in children with aplastic anemia. So, how is treatment of IBFMS different? Because there is increased risk of dysfunction or complications from organ dysfunction. So, the kind of chemotherapy regimens that is to be used in these children, the kind of immunosuppressive therapy, if required, or the conditioning regimens that are used in these children are going to be different from acquired aplastic anemia. Plus, they will require surveillance for cancer and other effects. So, this is the supportive care. You have to transfuse judicially with the most matched blood, even taking into account minor blood groups, and avoid transfusions from blood relatives to prevent sensitization to transplant antigens. Obviously, you have to use leukocyte depleted or irradiated blood products in these children, and other factors you could be taking care of. Avoid drugs like aspirin, intramuscular injections, and aggressive management of febrile neutropenia. So this is the prognosis if the child receives timely treatment. But HSCT is found to be better than IST on several accounts. Therefore, if available, HSCT is the treatment of choice. Thank you.
Thank you, Dr. Muji, for the pediatrician. I think it is very important that we notice that retic count is very important. So any child with pancytopenia, please do a retic count, do a peripheral smear, make sure there are no blasts. If you have pancytopenia, reticulocytopenia, and there is not much of macrocytosis or minimal macrocytosis, bone marrow aspiration alone is not enough. As highlighted, bone marrow biopsy very, very important to make a diagnosis of aplastic anemia. So please take a good biopsy specimen because cellularity can only be properly assessed based on a bone marrow biopsy. Also, Madam has highlighted that every aplastic anemia we have to rule out an inherited bone marrow failure syndrome. So do a chromosomal breakage, and this in this DNA we have easy access to next generation sequencing because some of the rare disorders are not free. Why is it important? Because immunosuppressive therapy does not work for Fanconi, it does not work for DKC. So you have to do a transplant, and the dosage of transplant treatment in acquired aplastic anemia and inherited bone marrow failure is completely different. You will kill a child with Fanconi if you treat him like an acquired aplastic anemia. So I think these all points have been very well highlighted, and we need is a good diagnosis and proper investigation so that ideal treatment can be.
Thank you, sir. All right. Yes.
Thank you, Dr. Puneet, for a wonderful presentation, and I thank all the chairpersons, Dr. Manav, Dr. Dhiren, and Dr. Taneja. So, you have any comments for me? Or should we? Thank you. I request Dr. Mukesh and Dr. Vipul to please. We have any announcements to make? So I request all of you to please join us for the lunch.